in central London at Guy's and St. Thomas's Hospital as a diabetes and endocrine consultant. And my main interest is quality improvement in healthcare. I also, during my postgraduate training and higher specialist training, I took a year out to do a Royal College of Physicians London Chief Registrar Program, which is a unique opportunity which they started in 2016. And the part of that role is that you come out of your normal postgraduate training. If you're training to in diabetes and endocrine, you leave that for a year and you join this Chief Registrar Program. And in this, you are 50% clinical and 50% of your role is leadership and management. So you work with the hospital leadership, the chief executive, all the middle managers, and you try and work on several or various quality improvement projects of your choice. So basically, this is an introduction for doctors into leadership and healthcare. And I did this program a year ago, and since then I have had keen interest in quality improvement, and I have done various quality improvement projects. So when you will see my slides and go through my PowerPoint, which I can share the slides with you later in like an hour or so, you can see the work that I have done. So today I wanted to talk to you about quality improvement in healthcare. So can I ask the audience, have you been involved in doing audits at all? And if one of the chairs can let me know what the audience say, what is the response from the audience? Have any one of you been involved in audits?
Dr. Aisha, yes, we have quality enhancement cell working in King Edward Medical University, and all the students have been continuously giving their feedback about their teacher evaluation, and most of the feedbacks, they are also being shared with the quality enhancement cell for continuous improvement. We are also having our participation in different ranking systems like QS ranking, THE ranking, and WURI ranking. And for all these, we have to keep certain standards. Our regulatory authorities are PMDC and HEC, and we are continuously giving them the feedback about the quality. Similarly, for research, we have certain mechanisms that have been devised for quality checks like Board of Studies, Board of Faculty, then we have Ethical Review Board, ASRB, Advanced Study and Research Board, and then we have regular meetings of research audit, and every 3 months, the whole process that has been implemented, it is being revised, and then again, new strategies and planning takes place according to the standards that we were able to meet, as well as about those standards that are still lacking, and there were gaps, and we try to fill those gaps.
So this is absolutely brilliant to hear. So this is basically your quality control, quality improvement at a higher level, where you're trying to improve provision of training, provision of research, you're trying to quality control it to make sure whatever comes out of KE is of high standards. The other aspect to quality improvement is something we as junior doctors can do, something at a lower level, something that is more patient facing, more patient centric, and more focused on improving the quality of service we provide to our patients. For example, the work that I was involved with was revolved around medical handovers. So now that is something which can be managed from top to bottom, but what we did as a junior doctor was we involved the junior doctors on the team to see how we can improve medical handovers from night to day, from day to night, from A&E to medics, because our patients, like as a new hospital, come into medical wards from emergency department, and then there is a handover between the medical teams from the day team to the night team. So we worked on safety of provision of this medical handover. So that was one example of quality improvement. So quality improvement in healthcare is at various levels. Yes, you're absolutely right. At the higher up levels, being very senior physicians, your responsibility is to ensure that training is of high quality, the research being delivered is of high quality. We as trainees, as junior doctors, who are going to be mentors of the future, have some responsibility as well. So you don't have to be a very senior physician to be involved in quality improvement. You can come up with your own idea and work on it and create a team and create influence and create the will to deliver change within the department you're working in or within the ward you're on. So I just wanted to base my talk around it, and I wanted to encourage the junior members of the team to take this up and don't be shy and don't be don't say that you don't have a voice. And if you have an idea of improvement, you can always take it to your seniors, and they can always and bring about the change you want. Methodologies, which I have in where you can go and read about it further. Processes linked together. So an example of a simple audit, which we used to do when we were really, really junior, was a surgeon would say, can you please audit my surgery list? So for example, a surgeon did 600 or 100 thyroidectomies for Graves. How many of these were really indicated? What was the mortality? What was the morbidity? That's a simple audit process. You audit a process against a standard guideline. You find reasons for change, and then you implement the change. Whereas with quality improvement, it's a more complex process. It involves audits, and basically it's a journey where you have identified that something needs to be changed, and you work on that change, and you use quality improvement methodology to deliver that change. Is anyone in the audience able to tell me, are they with me? Do they understand what I'm trying to talk about when I talk about quality improvement?
Dr. Tahira has written in the chat box about ISO certification. So I would request Dr. Tahira to please tell more about her experience with ISO certification.
Yeah. So all these certifications are regulatory bodies. So that is different. That's a different level of change. That doesn't involve you as a person leading the change, does it? Because, like, for example, in NHS, we have a regulatory body as hospital visits and rates the hospital time of response to treatment, etc. Ingrain, and what I wanted to talk about today was using your own small ideas and making them into projects, which then eventually lead to improvement of delivery of quality of service we provide to patients, or quality of research, like Dr. Cyrus spoke about earlier. So using your own ideas and then employing the quality improvement methodologies to bring about a positive change within the sector, within the department you're working in. And that can involve doing different audits, different data collections, designing interventions to lead to an improvement.
Dr. Aisha, would you please like to answer the questions that are being put in the chat box? Dr. Sadia has asked, what are the best 3 quality performance indicators for the hospitals?
Yeah. So quality performance indicators in NHS hospitals, number 1 is leadership. So when the CQC visits, they go around and see how effective are senior leaders in their roles. Are they good role models? Are they providing effective, safe care? The second indicator which the CQC in NHS looks at is the safety of provision of service to patients. Like, they look at the mortality, how many patients are dying when they come into the hospital. And the third and most important thing they look at is response to treatment. So for example, if a patient has been referred to a certain center for treatment or advice from a GP, how quickly does that hospital actually see that patient? And then every hospital has set up their own key performance indicators, which vary from different area and different area. For example, women's and children's services will have different key performance indicators. Like, for example, they will want to reduce their maternal deaths, they want to increase their live birth rates. Whereas for emergency department, their key performance indicator in NHS is that every patient who presents to an A&E needs to be seen within 4 hours of presentation. So that is their key performance indicator. Within medicine, we have different key performance indicators that every patient who has been referred by a GP for specialist advice needs to be seen within 18 weeks. So depending on the country you're in, depending on the department you're in, everyone sets their own KPIs, and everyone has their own markers of how they best perform. And then external regulatory bodies judge you on similar markers, but sometimes they set their own standards, and they then tell the hospital that we will be marking you against these. For example, for CQC, when they come to visit NHS hospitals, I told you they go by leadership, safety of care, response to treatment. Sorry, can someone read me other questions, if you don't mind?
Yes, Dr. Aisha, we have one more question. What are the challenges of delivering quality care?
So the challenges are manifold. It's such a good question. the thing in NHS, in healthcare, is you're never working on your own. You're working as a team. And even within the team, you have so many different layers. You have doctors, you have nurses, you have porters, you have ward clerks, you have pharmacists. So you're working as a team to provide a safe and effective care to the patient. So challenges are manifold. It varies from whichever department you're in and what question are you trying to ask, basically. So challenges could be, for example, if you want to change a service, the way it is delivered, you will have to identify your key stakeholders. You will have to find out people who are actually actively involved, who designed the service, who is your clinical lead. If you're not the clinical lead, you will have to get your allies on board. You have to share your vision. Your vision has to make sense to everyone. And then once you have your team on your side, you can then try and deliver change. But then again, if you are saying that something is not good, you need to go with evidence. Maybe we do a small audit, a quick data collection to say, actually, I don't think we are doing this right, because what has happened is we were referred 100 patients and we did thyroidectomies on all of them. And 60% of our patients did not even need it because none of them had this clinical criteria that met. So we need to reduce the number of surgeries we perform in the department. So you design and you have to create the ground for change by being very evidence-based and very clear, non-judgmental, non-observational, but very objective, and go with some data, present your evidence, get your team on board so that you're all sharing the same vision. And even then there will be people who will be like, what is she trying to do? And they will try and obstruct you. But as long as you have some key elements on board, key people on board, and you can keep making small progress in small stages. And what Dr. Saira also alluded to earlier was something called doing repeated PDSA cycles, which is plan, do, study, and cycle. So basically, if you think one intervention is going to work, you can re-audit your data, which you started initially, to say whether this intervention was a useful intervention or not, and whether you need to design something else and do something else differently next time to make a different or better improvement. I hope that answers your question.
Thank you so much. We have one more question over here. What is the scope of research in quality improvement in healthcare and comprehensive real-life practical examples in this context?
Absolutely. So in my presentation, I had shared 5 projects which I did in real life in a real hospital. And research in quality improvement is very nice and simple. All the projects that I did, I followed proper quality improvement methodology. I worked closely with a research and development team, and we published those papers. So again, you have to use proper QI methodology. Research and quality improvement is a properly well-defined term. And in my slides, I have attached links to where you can go and read more about it. And what you have to do is, once you follow the proper methodology that's required, you present your paper in the Squire format, which is where you give evidence, you give your background, you introduce, you have designed your interventions, you have got honest data collection, and you have shown either a change or an improvement, and you explain your limitations because you're working in real life. For example, another project which I was involved in, and a lot of, if you go, there's a lot of work being published now around quality improvement within the NHS and healthcare setting. So, for example, another project which I did was hospital at night service. So overnight, when you have very less staff, how do the medical team manage referrals for sick patients from all over the hospital? And then we used to have a bleep system, and there were complaints that they get bleeped a lot. So we audited the number of bleeps, the medical registrar, the medical SHO, the medical F1, and the site managers were getting. And then we looked into how can we improve this, because a lot of bleeps meant that people were not actually able to thoroughly assess sick patients due to interruptions from random staff members all over the hospital. So projects like this, and another project which me and my friends were involved with was the quality of board rounds. So every morning, before we start the ward round, we will go through all the patients admitted on the ward and go through the outstanding jobs, who needed to be reviewed by physiotherapy, who needs reviewed by occupational therapist, who needs to go home today, who is the sickest on the ward, so stuff like this. So there's a lot of examples out there, lots of publications on quality improvement. You can read BMJ Quality. You can read Future Healthcare Journal. It's an RCP, Royal College of Physicians journal. And there's BMJ Open, which publish a lot of stuff. The BMJ itself has a quality improvement section. And then there are other journals from America as well, which I have not published it yet, but they do a lot of quality improvement publications. Does that answer your question?
Thank you so much. May I request Dr. Tahira Amjad to kindly speak with Dr. Aisha? I have written her chat box. Please, Dr. Tahira Amjad, over to you.
I think there are a few other questions in the chat box that are very important, like what are the main reasons that affect quality in health systems, and how can this be made better, especially in the context of Pakistan? And I think this is a very beautiful question.
This is a very good question. I agree. So quality in healthcare in Pakistan, obviously your biggest challenge is finances. But within the finances that you have, it depends which area, which department you're in, how effective leaders do you have within that department, what their vision is for their department. Because if you have a clear vision, a good leader, you can achieve a lot. And then it also comes down to the rest of the team, how driven, how motivated, how hardworking they are to the cause of delivering good care. And then I don't want to talk about politics and the rest of the stuff because that exists everywhere. It's how we best manage it and how we best mitigate the risk to our patients. Can you just read the question again? There was two parts to the question, which I've forgotten the second part. Can you just read the question again, please, Dr. Saira?
Hello.
Actually, there are so
Am I
many
audible?
questions. Yes.
Yes, okay, next, we can go to the next question then.
Okay,
It's very
thank
good.
you so much. Yes. It is by Usama Kamar that
Yeah.
given the lack of funding for healthcare in countries like Pakistan, how can we improve the quality within our given resources?
So you don't need money to improve quality, you need will. You need goodwill and you need to work hard and you need to come up with an idea and you can make small changes. You don't have to think about the whole country. Even a small change can have a ripple effect and make a difference. As long as you have the will and energy to commit to a cause, I think you can make a big difference. You don't have to rely on others. And a lot of work can be done without money as well. We don't realize we get constricted by our boundaries, but these are in our mind most of the time. I hope that answers the question. Next question, please.
Yeah. Next question is why it is difficult to measure quality, especially in rural and urban areas of the for certain healthcare standards.
It shouldn't be difficult whether you work in a tertiary center or in a rural area. You should have some form of auditing availability. You need to be able to see what is going on with the patients. I don't understand. Like, for example, you will have the same 10 or X amount of patients coming into your hospital in Mu or in a BHQ or a THQ. Again, I don't think that's a difficulty. It might be a perceived difficulty, but as long as there's a will, there's a clear vision, there's leadership, and most importantly, medical leadership, you should be able to get to the bottom of the problem and hopefully identify problems which can be
Yes.
addressed pretty quickly.
But I
Next
totally
question.
agree. Yes.
Yes.
Yes, I totally agree. Yeah, because in urban and rural areas, whatever the resources are present, the same
Yes.
patient can be referred from a rural healthcare center to a tertiary care center, and the quality of the rural healthcare center should be according to the resources at that place.
Exactly.
While in tertiary care, hospital resources would be at a larger scale,
Yes.
so the quality doesn't depend actually on resources,
No.
but also on the mindset that in
Absolutely.
tertiary care there are so many different specialities and so many different resources are required,
Yes.
and so the quality standards they become more stringent as
Yes.
compared to a rural health center.
Yeah.
So the quality would remain excellent perhaps
Yes.
and
And
if they are
easier.
giving all those
Yes.
services that are required from their perspective. Yes. All right.
Precisely.
This
Yes.
is another very good question by Dr. Aware. Yes, he said, how much importance is the role of family physicians in healthcare, and to what extent the family physician can provide health services with quality?
Oh, this is in England. We rely on family physicians massively. You see most of the bulk of the patients, and you are the one who are controlling referrals to the hospital. You are the one who are controlling referrals. You are the one who are managing the sickest patients in the community. Obviously, you need to refer them on, but we rely heavily on family physicians, and we call them general practices here. So patients with minor illnesses who do not need emergency intervention, who do not need surgeries or urgent medical intervention, or sometimes patients with long-term medical conditions, they all go to their GPs, their family physicians, to sort out their long-term conditions. Unless something becomes really complicated, which requires specialist input from the heart failure team or the diabetes team or the endocrinologist, only then they get referred on. So we in England are relying very heavily on our family physicians, and most of them do an absolutely brilliant job within their general practices. They have setups where they have nurses, where they have a team of doctors who do a lot of provide
Aisha?
contraception advice, provide and do a lot of work in the community. Does it answer your question? If there are more questions, please can we move on?
Yeah,
Yes.
there is
So,
one more comment that is from Dr. Tahira. I was in ISO certification of a hospital and
Yes,
assistant QMR of FUI, both campuses. All the
amazing.
procedures and the manuals were developed. Internal and third-party audits were conducted. As a lead
Amazing.
auditor, also went through the whole process. In my opinion, the quality
Mhm.
process should continue with regular internal and external audits. Otherwise,
Absolutely.
you will be yourself compromising the quality. It's a great tool
Absolutely.
for the healthcare and needs to be
Mhm.
given a serious attention.
That is
Very nice
absolutely
comment by Dr.
top.
Tahira.
Yes, very, very right and excellently written. And yeah, I completely agree with this. Yeah.
Right. Another question by Dr. Khansa. What are the major barriers of delivering quality healthcare services in your country?
In our country, so just like Dr. Saira just mentioned now, the barriers differ from hospital to hospital. For example, when I was in a small district general hospital, the barriers were around difficulty with staffing, difficulty with quality of the staff you had. Obviously, you're not allowed to say it like this now, but obviously people had some different interpersonal challenges. There were some issues, like I would never say money or resources are a challenge, because you can always find money. There's always a resource somewhere which you can utilize to make a change. But in a DGH, so these were the downsides, but the positive aspects were not many people are involved in change, so you can change things around very quickly. Whereas as compared to a center that I'm working in now, which is a large tertiary hospital in central London, there are so many layers, there's so much bureaucracy, there's so many different teams, and delivering change becomes more of a challenge in such a hospital. Whereas it's really resourceful, it's the richest hospital in the country, the second best in the world, excellent place to work at. But if you want to change anything, it requires a long time and a lot of effort, because you have to go through so many people. The chain of command is so high. But again, the end product is absolutely amazing because you have had input from so many people. So change is a journey, quality improvement is a journey. You can't You just need to have a clear vision as a leader as to where you're heading to, and you just need to learn to work with people. You need to employ audit tools like Dr. Tahira mentioned, and then re-audit your processes. And I mean, it's an absolutely enthralling experience if you're involved in quality improvement, because you see the change, you see the services develop over years, and you want to sustain the positive changes that you have made over the years as well. So the challenges differ. In NHS, our challenges are mainly around staffing, sometimes around a lot of bureaucracy and paperwork, but I think almost quite similar to Pakistan.
Thank you very much, Dr. Aisha. Wonderful experience of having your talk. And there are so many questions that have been brilliantly been asked as well as answered. And there
Amazing.
were so many beautiful comments. Yes, we really enjoyed your session. I would request Dr. Sadia for a vote of thanks to all the participants as well as our guests and the organizers, especially Dr. Athar Saeed and Dr. Tavinder Dugal, because they are phenomenal in producing CAMCA UK lecture series. And we are so lucky that we have such great organizers in our team. Next to
Thank
Dr.
you.
Sadia Rafiq for concluding remarks as well as vote of thanks.
thank you so
Thank
much,
you.
everyone. Professor Dr. Sara Afzal, it always a blessing to learn from you. And thank you so much for guest speaker, Dr. Aisha Saqib. It was really nice treat to listen you, and your knowledge is, mashallah, very nice. So I thank you all the participants over here. And there are a lot of questions still in the chat box. But we are short of time. So thank you so much for the organizers, Dr. Athar Says and Dr. Tabina Dugal, as well as our patron-in-chief, our worthy Vice Chancellor, Professor Dr. Mahmood Ayaz, Professor Dr. Sara Afzal, our coordinator, Dr. Fiya Salman, and I'm your moderator, Dr. Sadia Rafi. And I thank you all the participants who are in this session. And inshallah, we will see you again in the next lecture of our guest series, which is going on. Inshallah, see you soon, all of you. And have a nice day ahead.
Thank you.
Allah.
I will email you my slides as well so that you can pass it on to the participants if they want to refer to.
Okay, okay, sure.
Thank you very
so
much.
Dr.
Thank
Aisha.
you.
Thank you so much.
Thank you.
Take care. Allah Hafiz. Thank you. Allah Hafiz.
Allah Hafiz.
Allah Hafiz. Stay blessed. Allah Hafiz.